Welcome everyone to today's webinar, The Prevention Protocol Cutting Pressure Injury Incidence at Mayo Clinic, a case study. On behalf of Becker's Healthcare, thank you so much for joining us. Before we begin, I'm going to walk through a few quick housekeeping instructions. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and it will be available after the event. You can use the same link you used today to log into the webinar to access the recording. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser. You can also submit any technical questions into the Q&A box. We are here to help. With that, I'm so pleased to welcome Anne-Marie Cooley, Senior Director of Clinical Development for Advanced Wound Management at Smith & Nephew, responsible for pressure injury prevention. Anne-Marie has spent the last 20 years in various business and clinical development roles in the patient monitoring market. She joined the startup Leaf Healthcare in 2014 as Vice President of Market Development, where she was responsible for clinical evidence development and clinical operations. I'm so thrilled to turn it over to you, Anne-Marie, to kick off our presentation today.
Thank you so much. I appreciate that introduction. I apologize to everyone that I'm off camera. I'm actually sitting in my home office without the power on. So this is just, I guess, how the pandemic goes. You got to be able to just roll with that. So before we get started talking about hospital-acquired pressure injuries, I just wanted to ask you to participate in a pandemic pressure injury survey we're doing in collaboration with NYU, Rutgers University, and Mayo Clinic in Rochester. We're just interested in finding out about different nursing practices, staffing, administrative practices as they relate to pressure injury prevention during this really challenging time that we've all experienced in the last year or so, and really appreciate your answers to that. So let's dive into pressure injuries. Even without the pandemic, what we do know about hospital-acquired pressure injuries is that they are on the rise. The most recent data we have from the Agency for Healthcare Research and Quality is that while we've done a tremendous job with all other hospital-acquired conditions, CAUTIs, CLAPSIs, C. diff, falls, all of those things that we've had in major initiatives around hospitals to reduce. In the meanwhile, we've actually pressure injuries continue to be on the rise, while all other hacks have decreased on average 13%. They're also very expensive. So a recent study that was based off of 9 million patient records in the Premier database showed that on average, the additional costs related to a pressure injury patient was over $21,000. They had 9.5 additional bed days and were much more likely to be readmitted within 30 days to that hospital than patients who did not have hospital-acquired pressure injuries. And that statistic rises, the cost rises as patients develop those in critical care. What was really interesting about this study actually was also the correlation between pressure injuries and other hospital-acquired conditions. So a patient who develops a hospital-acquired pressure injury is twice as likely to have a fall during their hospitalization. They're 3 times more likely to develop urinary infection, 4 times more likely for VTE, and 5 times more likely to develop a ventilator-associated pneumonia. Obviously, really the oldest intervention that we've had for pressure injury prevention was patient turning and repositioning. This literally started with Florence Nightingale in the Crimean War Hospital in 1860. So a war hospital, you can imagine, that's sort of like today's level 1 trauma center, really devastating traumatic injuries and otherwise healthy people. And she really figured out that by repositioning these patients, we could manage the sustained pressure and try to avoid pressure injuries. And literally the 2-hour protocol came from this environment. It took her nurses 2 hours to start at the beginning of the hospital before they finished and would start that rounding again. So that practice really got its start over 150 years ago. What we do know about turning and repositioning, though, is that it's just not front of mind always in a busy, task-saturated clinical environment, especially as we climb up the acuity ladder. Adherence to these turning protocols is low, and the med-surg patients. Critical care patients with pneumonia are turned even less frequently than just critical care patients, and so on. So the other thing that we see is that there's great amount of variability and bias in terms of repositioning based on time of day. So night shift, patients in the night are turned less frequently than patients in the day. And patients with high BMI are turned less frequently than patients with low BMI. And male patients are turned even less frequently than females, regardless of their BMI. Might have to do with their size, perhaps. Men are bigger, heavier. BMI is just sort of standardizes all of that. But that might be perhaps the reason why that there is such a bias in repositioning based on that kind of patient characteristic. So we developed the Leaf Patients Monitoring System to try to really eliminate some of that variability and help clinicians remember when patients are due for repositioning, so that we put that reminder out there when their individual patients have been immobile beyond the time that we've prescribed for them to be their repositioning interval. The system is really simple. It's a patient wearable sensor. Patients wear the sensors on their chest like a sticker. It attaches on kind of standard IV film dressing, and it's monitoring all of their position changes, orientation in and out of bed, repositioning in bed, in chair, and then if they become well enough, or if you have early mobility initiatives, even in critical care, it will basically monitor all of their ambulation events, how many steps they took, etc. And it will put all of those alerts into just visual color-coded cues only. There are no audible alarms, and it's only giving you a red line when a patient's been immobile for too long, and it's only calling attention to those patients who need that. So if you have a patient who's some of the time turning on their own sufficiently, it's going to reset their turn clock automatically, and it really only tries to capture the clinician's attention to those patients who require assistance in repositioning. What's unique about the system is it's not just a turn frequency reminder. There are some systems out there in the market that work very much like an oven timer. You set your oven timer for 2 hours, shove the roast in the oven, and 2 hours later, it'll ding whether the roast is overcooked or undercooked. The Leaf sensor is, because it's monitoring, it's based on a patient's own movements, it really is resetting automatically whenever the movement was sufficient to offload the tissues. But it's also looking at the adequacy of the turning. What's interesting about repositioning, it's such a fundamental nursing skill, but it's no longer taught in nursing schools anymore. And so it is really looking for that adequate offloading turn to offload the pressure from the sacral area before it will say, yes, this is an adequate lateral turn. And then the third thing it's looking for that tissue recovery time in between turns. So if you have a patient who has a little transient movement, let's say linen change or something like that, we wouldn't want to have them get another 2 hours on the back, if that offloading period was just very short. So we're really looking at these three different things constantly and putting those into through an algorithm we call integrated positioning index into very simple red, yellow, green. Does my patient require repositioning? So what kind of clinical evidence does this system have? It's been study over study to show that it really takes that average turn adherence, which is somewhere hovers around 50%, and takes that above 90. regardless of clinical setting where it's being used. In one study at a large medical surgical unit, patients were monitored blindly before, just to kind of get an idea as to what the repositioning practices on the unit were. Now, their results were 64%. This is a med-surg unit, so patients are a little bit more mobile than they would be in a critical care unit. Once those turn alerts were revealed and staff was trained on how to respond to those turn cues, that result rose to 98%. And the difference in the isolation subgroup of patients was even greater. It went from 48% to 99%. It's also been shown to reduce that variability in care delivery we talked about earlier. So by having those visual cues available, it really helps all the shifts provide the same predictable care. Whether the patient is admitted there in the night shift or admitted on a Saturday versus a Wednesday, they all get the same thing. And there are ways, for example, for night shift to pause turn alerts to indicate when sleep is required for delirium prevention. So it really is, the system is really designed to, with those kind of practicalities in mind, pressure injury prevention or patient repositioning isn't always clinically the number one thing to do with the patient, obviously. Most importantly, though, the system has been shown to significantly reduce pressure injury incidence. This was probably one of the largest studies ever done in critical care on pressure injury prevention and repositioning. It was done at 2 critical care units at Stanford in California. Patients were randomized to 2 parallel arms. There was the leaf intervention arm where clinicians were using the system as it was designed, and then there was a blinded arm where patients wore the sensors, but all those visual cues were blinded. So nurses were using traditional reminders, whatever they were using as memory ticklers before, to remember when to reposition their patients. Over 100,000 hours were collected in this independently conducted study, and there were 73% fewer hospital-acquired pressure injuries in the leaf arm compared to the control arm. All right, I would now like to introduce our next speaker, Robin Gasparini. Robin is a nursing administrative specialist at Mayo Clinic in Jacksonville, Florida, and she has a really exciting case study to share with you. Robin's focus of her work is strategic planning for the Department of Nursing, and in this role, she leverages improvement science to advancing nursing outcomes. The bulk of her career has been spent in a variety of roles across Duke University Health System. She's educated as a clinical nurse specialist with a Doctor of Nursing practice from Duke University School of Nursing. And Dr. Gasparini brings nearly 20 years of practitioner experience in critical care and cardiothoracic surgery. And she has a particular passion for and has published articles around patient and family-centered care delivery. Robin, take it away.
Thanks, Anne-Marie. Appreciate that. So before we get started, I just want to share that while this is sponsored by our Smith and Nephew partners, that the content that you're about to see is really specific to the quality improvement project that we did at Mayo Clinic, Jacksonville, and is solely used for informational and education purposes, but does represent our own findings for our work. So as Anne-Marie mentioned, I am at Mayo Clinic Jacksonville in Florida. We're a 304 bed operation. We are widely known, especially in our region, as one of the best ranked hospitals in Florida, according to the U.S. News and World Report, and have lots of subspecialty areas. Mayo Clinic specifically is known for their quality care delivery, and rightfully so. We've had some tremendous outcomes and have a great reputation for that quality care. That said, as Anne-Marie mentioned at the start of the presentation, we were seeing an increase in our hospital-acquired pressure injuries, and it was pretty significant. And it was the only hospital-acquired event where we were really seeing spikes, where our interventions didn't seem to be effective. When we looked at our peers across the country through platforms like the National Database for Nursing Quality Indicators, we were much higher than we wanted to be. In fact, we were well over the 50th percentile, which is not a metric that an organization like Mayo Clinic wanted to own. So we really wanted to do a deep dive and understand what was driving these unfavorable results in our organization. One of the unique challenges that we have in nursing is that our nursing interventions are often not documented in real time. So when we have patients on machines or other technologies, we have the ability to provide more real-time documentation. The demand on nurses, we just don't have that. And so, documentation becomes a lower priority. And honestly, sometimes simple interventions, nursing interventions also become lower priority. So we had a really difficult time deciphering whether this was a problem in our organization where we weren't providing an intervention or whether we weren't documenting the intervention. But on deep dive, we had no evidence of either. And so, we did a lot of focus groups to really try to understand, the culture across our units. And what we learned is that we perceive that we are doing the standard of care for the prescribed time every 2 hours, right? We believe that we're treating our patients. So there was a disconnect, and we didn't fully understand what that was. So when we saw the Leave product, we were excited for a couple of reasons. It seemed like an innovative way to transform our compliance with those turning protocols, thereby helping us reduce some of those pressure injuries. We also knew that there was an ability to link this sensor to our documentation platform if that was something we wanted to invest in. So having that real-time nursing intervention documentation. But the tool itself, even without those interfaces, was something that we could really leverage to enhance our team communication around those turning needs to help us really understand if we were providing the prescribed turning the way we thought we were achieving that. Lastly, this really just kind of emphasized that reduction of pressure injuries is something that we really want to see in our organization. It's a priority, and we take that very seriously. We wanted those better quality outcomes for our patients. So we did a 3-month study in our ICU. So it was a surgical ICU and a medical ICU. We were looking for 4 simple outcomes related to this Leave therapy intervention. Specifically, as the literature indicated, are we really turning the patients for the prescribed time as we think we are? Will it have an impact on our pressure injury rates? And then we know that this tool is marketed as an early mobility tool. There's a lot of evidence out there to suggest that early mobility interventions have a lot of positive outcome impacts to include, decreased length of stay, improved circulation, improved lung function. So we thought, let's see if there's any impact to our ventilator-associated events. This was another area where we were trying to take a deeper dive and understand things that might impact those results. And then lastly, we wanted to see if we had any kind of reduction in the wound care consults that were not triggered by a Braden score, right? So like many organizations, we automatically put in a consult for patients meeting certain criteria, but anything additional to that means that that patient has had some kind of concern or potential injury. So we're hoping to see those metrics reduce as well. So before we got started, we really had to do a lot of work level setting and kind of talking about what our goals were and understanding what the triggers were for the pressure injuries that we were seeing in our organization. So our CNS team did a deep dive of every pressure injury that we've had in our ICU that was sacral related to identify what other factors might have been potentially causing that. So we could isolate the patients who could really benefit from this therapy. And from that developed our application criteria. So what did we find? Well, we over the 3-month period, monitored 105 unique patients for over $11,000. And we noted a huge improvement in our turning protocols. But that didn't happen overnight. It happened with time. And so we were really able to kind of get a better sense of where we were at baseline with some of those turning protocols and see that improvement with this therapy. We also saw more equalized distribution of our patients' positioning rather than just on those lateral positions. And we're able to demonstrate that with reports through the tool. The variability really decreased with our turning as well. So something that I thought was important is unintended biases that we might have had in our unit that were preventing some of the turning for our patients weren't present for those patients receiving the sleep therapy. We were able to see that equalized turning distribution and that decrease in variability. So that was a really important finding. And we did all of this without hiring any additional FTEs to support it. So I know what most of you are interested in is, did we have an impact on our pressure injury reduction rates? And indeed we did. We saw a very significant reduction during our pilot period, 65% rate reduction and a 67%, incident reduction and a 67% rate reduction, which we felt was really significant. Out of the 105 patients who received the leave therapy, 97% of those patients remained free from any kind of pressure injury. We did see 7 injuries during the pilot period, and 3 of those patients never received the therapy for leave, despite maybe meeting criteria to receive the sensor. The other patients who maybe did receive the leave therapy were noted to have some pretty significant gaps in their turning, which helped us with our deeper understanding of lessons learned, right? So things that might have impacted those patients' care delivery, like, long pauses in turning intervention because of sleep enhancement protocols. So really trying to align and prioritize the care and understanding intent behind those protocols so that we're still keeping our patients safe. And we'll talk more about that. The message here is really that all of our patients who received the leave therapy and the prescribed turning protocols as indicated remained free of any kind of pressure injury. The impact on ventilator-associated events we found fascinating. So 92% of the patients receiving that therapy remained free of a VAE. We were excited to see this. We don't believe that there's a direct causal relationship, but it's something that we're really excited about investigating further and seeing what other opportunities we might have with these early mobility interventions. And then lastly, I have to admit, we really missed the mark on our wound care consults. We saw an 87% increase. And for a physician like myself, that's a value-added position. I was really excited to see this. Our staff had such great awareness of pressure injuries and really trying to make every effort to reduce the pressure injury rates that we were seeing, that they partnered with their resources more frequently, even outside of the Braden score triggering that consult. What this also showed us when we looked at the types of incidences that our wound care team was being consulted for, that we had a higher acuity during this time in patients who were really at risk. So we contribute this to just great awareness on the part of our staff and really leveraging the proper resources to make the right decisions to protect their patients. So really exciting results here, and we were happy to say that we did not meet our goal here. So something that's important to us during this pilot period was our return on investment. We were able to keep our costs at about $25,000 for the pilot, which knowing the cost of a pressure injury, which is one of those costs that's really difficult to see and trend and track over time, But understanding the average cost to treat a pressure injury, and that costs are the responsibility of the hospital, we were able to demonstrate a $500,000 return on investment for just the pilot period. So if we translate that to our annual reduction of pressure injuries, we were looking at upwards of a $3 million cost savings. So really significant if leveraged properly. We had a number of lessons learned to help impact staff adoption and full adoption. We were pretty aggressive at first with our turn angles being Mayo Clinic. We wanted to really see those quality turns. And we found out that we didn't have the proper support for our staff to set them up for success. So those pillows that are in the ICU just are not meant for turning. So we were able to purchase wedges that were available in our car room so that nurses had quick and easy access to them to help maintain their success with achieving and sustaining a quality turn. And that was really important for our team. A lot of our focus had to be spent on understanding what a quality turn is like. I think we do a remarkable job of elevating that shoulder off the mattress, but not really turning the patient core, which this sensor is designed to measure. And so really focusing on, quality turns and how we sustain those quality turns. But I would say that our largest lesson learned throughout this whole pilot period and in, subsequent adoption of the tool is that it was really important for our organization to have solid change management skills and to be on the same page about why we were investing in this, this device, what we were looking for during the pilot period, and how we could really have significant positive results in our patients. So using a change management approach across our entire leadership team was probably one of the most important and fundamental things that we had in place in order to achieve a successful adoption. Since our pilot period, and just in summary of our findings, we saw a fairly significant reduction in our pressure injuries. It was really important for us to identify how we could continue to see that reduction and achieve even higher rates with better utilization and adoption of the tool. We have since expanded this tool across several units in our organization, so beyond our ICU area, for units that were demonstrating pressure injuries at increased rates. And then we also started to build a Epic integration, flow sheet integration, so that we would have more accurate and timely documentation of the nursing interventions that we're providing to help support the work that we're doing. In addition, this work only helps us as we continue to seek magnet redesignation and look at other standards that we're trying to meet to demonstrate that we are a high-quality organization. So with that, I think we have a number of questions that we'd like to address.
Yeah, thank you, Robin and Anne-Marie, so much for that great presentation. We can now begin, as Robin said, today's question and answer session. And for our audience members, you can submit any questions you have by typing them into the Q&A chat box on your webinar console. So let's get started with the first question. Could you tell us what have you done since the pilot?
Yeah, so we were so thrilled with the results of our pilot that it was really important to us to share our results broadly across the organization, not just across our ICUs, but we saw this great impact. And we really received a lot of positive feedback and excitement around this tool. So since implementation in our ICU, we have fully adopted. So we stopped our pilot period to measure our results and to make some decisions as an organization, we relaunched with full adoption in our ICUs. Since we've expanded to our progressive care area, a general care area, neurology, and one of our COVID units, and are seeing great success in those areas as well. We have 2 additional units that we plan to expand to in the next 2 months. So this allows us full adoption of this tool across our organization, across all 304 beds, which really helps with that continuity of care, right? So previously, when it was only being leveraged in our ICU, we could only use it there. The sensor didn't pick up or track when that patient was transferred, and we would remove the device. Now that we have the infrastructure across our organization, we're really able to provide that same continuity of care and intervention no matter where that patient is. And so that's been really helpful. Something else we've done since our pilot period was really try to understand opportunities to leverage the tool on patients who maybe didn't seek the therapy. And we had to take a deep look at that application criteria that I shared with you earlier. What we found is that the application criteria was a little too broad, and we tried to make it broad intentionally. But the feedback we received from our teams is that they really needed something a little bit more black and white. It left too many opportunities to maybe not consider a patient who needed that therapy. So we've partnered with our staff and with our wound care team and have really simplified the criteria. Part of that due to the fact that the 48-hour window was no longer important, given that expansion had occurred across our organization. So it didn't matter if that patient was being transferred that evening or the next day, the sensor would still be applicable. So we set our criteria to really focus on patients that had grading scores putting them at the highest risk and using that to support intervention. And we've seen a much stronger sensor utilization and increased reduction of those rates since then because more of our patients are receiving the therapy.
Well, thank you so much for that response. Another audience member wants to know, what were some of your biggest learnings from the pilot?
Mm-hmm. It's a great question. I think I really go back to approaching our pilot and adoption, leveraging a change management approach. Having all of our leaders truly support and understand the importance of pressure injury reduction, not only for our patients and their quality outcomes, for our nursing sensitive metrics that have, other impacts on our important rating metrics, but really understanding that as a priority and being able to speak to that and supporting that. So it's probably our biggest takeaway. I would say something else that we really, that we learned that's important to note is that staff perceived this tool to increase their workload initially. And I think it's because, truthfully, it did increase our workload. We had the perception that we were turning patients every 2 hours, but in reality, it was much longer than that, upwards of 4 hours, sometimes 6 hours. So we weren't providing the care that we thought we were providing. And so when we started doing that on a routine cadence, whereby it was required for reperfusion, then the perception was that this was a lot more work. What we were able to demonstrate over time is that we weren't doing what we thought, and that this intervention really was significant into helping our patients' outcomes. And so we had that buy-in and support from our staff. But that was probably one of our biggest learnings, I would say.
Absolutely. Another audience member question includes, how did you come up with your risk criteria for monitoring? And have you modified the criteria at all since the pilot?
Right. So I hope I addressed that already, but essentially from a cost savings perspective, trying to think about early on who would get the sensor and who was at most risk, and where the sensor would be most beneficial. And what we found is that having that broad criteria really put us at risk for lower sensor utilization, as opposed to treating the patients who really needed to be treated. So our recommendation and our change to that application criteria was really to be more specific, more black and white, less gray, and base it solely on the Brady score, which we know to be a primary indicator for pressure injury risk.
Definitely. Thank you for that clarification. Another question is, how did you justify the cost to leadership?
Mm-hmm. Yeah, it was a hard sell, and not necessarily just for our leadership, but for our staff as well. So everybody really wanted to understand why we would invest in this kind of tool and what other options we had. And really, the pilot criteria spoke for itself. So being able to see a 67% rate increase, and understanding not only the costs to the organization of that pressure injury, but the impact on patient care and quality outcomes. So being able to justify and show that return on investment was critical. We went from having, on average, 35 to 40 pressure injuries a month in our unit, to having none in months, and maybe only 1 or 2 per quarter. So very significant reduction. We were able to demonstrate a high return on investment when we averaged in those costs. Again, part of that was really leveraging those change management tools so that our entire team, from the bedside staff to our most senior leaders, were really aware of the intent, the direction, and the goals for utilizing this device.
Great. That was a great answer. Thank you. Another audience member would love to know, does the data collected from the application of the leaf become part of the permanent medical record?
So that's a great question. As an organization, you have the ability to indicate what components you would like to have in the medical record or not. So our organization is very strategic about what that looks like. The interface that we've created only documents the patient's positioning and sends that continual feed. It still requires a care team member, a nurse, a tech, to validate that that is the information we want to pull over. So very much like vital signs, the machine might send that information to the computer, but it's up to us to validate that is correct, and that's the data we'd like to record. So the positioning data becomes available and evident in that flow sheet, which really helps us. It monitors both the nursing interventions as well as the patient movements. And it demonstrates that our patients are moving, whereas prior to that interface, there was no documentation and no evidence to support that the patient had moved themselves or that those nursing interventions were applied. You have the ability to tailor that any way you want so that more information can come over in the system. But certainly from a risk perspective, right, I think every organization has an opportunity to identify what that looks like for them.
Gotcha. Thank you for that explanation. Another audience member would like to know, they said, you've spoken about reduction in healthcare-acquired pressure injuries, but was there a significant reduction in severity of stages? For example, did you eliminate all stage 3?
That's a fantastic question. And I don't have that exact data in front of me, but anecdotally, I do believe that there was a reduction, right? What we were seeing were a lot of those deep tissue injuries where we were catching injuries much too late, so that progression had already occurred. What we're finding now is that we have very few injuries at all. We are seeing some stage 1s and some stage 2s, but overall the severity of those injuries are much reduced. So I would have to do a deeper dive into that, but I would say yes, I do feel like we've been able to do that. A lot of that depends on if the patient received the sensor, right, as a therapy. So patients not receiving the sensor might not have that reduction. We might still be identifying those pressure injuries much too late. But patients who receive the leaf sensor turning therapy are much less likely to develop a pressure injury. In fact, if we're turning them as prescribed, we've had no incidences of pressure injuries, and that includes anything sacral or other lateral bony prominences to include the heel, elbow, things like that. So we really saw a drastic reduction there from sensor use.
Another audience member wanted to hear a little bit more about staff and what their perception of everything was. They asked, did the staff feel like they were being watched, like Big Brother almost, making sure that they do their job turning?
I really appreciate that question. That is absolutely the initial perception of our staff. We had to do a lot of work with them to indicate that, again, going back to that change management utilization, this was not meant to be a punitive measure, right? We weren't using the tool in a negative way. In fact, the detailed reports that are available for every single patient receiving this therapy were only looked at by our leaders in our organization when a pressure injury occurred to help us understand if we really did everything that we could have done, right? So those reports help us determine if the pressure injury really, truly was unavoidable and we did everything that we could, or we lack documentation, we lack evidence, and that pressure injury was preventable. So the sensor helps us mark those injuries as unavoidable if that's the case. So we had to really work with our teams to build that trust and prove to them that this wasn't designed to catch them not doing the work that they were supposed to do. We really had to deliver this as, we know that things happen and that we're not able to provide the quality care that we want to all of the time because of that increased demand. So by leveraging a silent visual tool that everyone has access to, helps us stay on the same page, prevent the time it takes to track and communicate those turning needs or assistant needs, and so that we're all in this together and keep those patients on an adequate turning schedule that protects them. Our goals were not 100%, right? So when we look at our turning compliance, what we know from the evidence is that if we achieve an 85% turning compliance, we're more likely to prevent pressure injuries. So our goal was above 85. It was between 85 and 90%. But the message there is that things happen. We know that you're doing the best that you can do with your care provisions. This is an effort to help you with those care provisions and set our nurses and our patients up to have the best possible outcomes. And so when we tried to message it that way, and the staff were able to see by the end of the pilot the significant results that the leadership team was seeing, then we had much more, trust and validity of the validity of those results. So it was a process. And again, that perception that this increases their workload and that they're treating a tool as opposed to a patient. But that's only because we were in those rooms more often, as we should have been, and as our perception was that we were.
There's so many great questions coming in. Robin, I'll ask you another question kind of related to what you just spoke on. This audience member wrote, you indicated nurses did the increase in turn protocols without any new FTEs, but did they complain about an inability to do other nursing tasks?
We did not see slippage of any of our other quality metrics during this time. I really value that question, because when you focus on something else, right, you lose focus in other areas. I think what's unique about this tool is that, the intervention that was required is not a time-consuming intervention, especially after we prepared our staff to achieve and sustain a quality turn. Once they had that information, then they were able to do those interventions with little time commitment. So it really was just the awareness that it needed to be done. Again, initially, they felt like it was time consuming, but not that it was keeping them from other tasks per se. The focus there really was, are we achieving that quality turn? What can we do differently? What tools do we have to support you? By leadership investing in the additional resources like the wedges, helped show our staff that we wanted them to be successful and that we wanted them to go in and create that quality turn with as little time as possible and be able to sustain that quality turn. So it was a process. It didn't take us too long to achieve that trust. But I would say that, that staff were able to see the value of not necessarily having an additional FTE, but leveraging these tools, and that we were still able to achieve the other work that was required. Something unique about this sensor is, today when we have more patients on isolation than before, we want to make sure that staff know that their patients have that quality turn before they leave the room, right? You don't want to have to go in and out of that room more than you need. And so the sensor actually has a visual on it, so that in addition to the monitors or the kiosk where the nurse is documenting, that has a small pop-up window of their patients and their turning positionings and status, the device lights up red, yellow, or green. And so it's easy to interpret, exactly what side the sensor is registering the patient on, and you're able to provide that intervention before you doff your isolation, protective equipment and get out of the room.
Another audience member would like to know how long the battery lasts in one leaf sensor.
Yeah, it's a great question. We have seen variability in this based on our utilization, right? How often we're tapping that sensor itself, and how often we're turning that patient, asking it to read. The manufacturer says that the battery lasts, I believe, 16 days, 15 to 16 days. We're finding that depending on utilization, we're seeing that a little bit longer, so that it stays with that patient. Fortunately, most of our patients aren't in the hospital quite that long. So the few patients that we have that are longer term residents of ours, we've only had to replace 1 or 2 times. And we've seen it last up to days, just shy. So.
In the last couple of minutes here, we'll have a couple more questions. What was the increase in WOCN consults sustained? And did you have to add FTEs to your WOCN team?
That's a really great question. We were looking to do that anyway, right? So evaluating that value-added service and its impact on our staff. Initially, we did not have to add additional staff for the wound care team. We have seen some sustained numbers in our wound care consults, but not quite as high as we saw during that pilot period with that increased awareness and our higher acuity. Because of the gray areas in our application criteria, staff are really consulting our wound care experts to help to help identify, is this patient really a candidate? Should we apply a sensor? What other interventions should we have? So that really helped increase that consultation. When we reduced or limited that application criteria to be much more simplistic, those types of partnering consults reduced. That said, wound care is something that we value in our organization, and we only had a small number of FTEs to support that for our entire hospital. So we have put in proposals to increase our wound care team. I would say that is independent of the LEAF system and not a direct result of leveraging this tool.
One audience member wants to know, in regards to preventing delirium, some patients aren't always turned at night to minimize stimulation to the patient. So were patients still regularly turned at night?
Yeah, that is a great question. And, it was those reports that really helped us, again, not from a punitive measure to say staff weren't doing something, but to really do a deeper dive into the culture of where are pressure injuries developing and why. And what we found out was that those patients that had sleep enhancement protocols to prevent delirium weren't always being turned. In fact, quite frequently, we probably weren't disturbing those patients. So this allowed us to go in and really level set with our staff the intent behind the sleep enhancement protocols, that it's not simply we don't disturb between evening hours. It's really about all of the other interventions that we're trying to put in place to prevent delirium, which is important. Things like caffeine reduction after a certain time period, and making sure that we're getting those patients up and that they have some attempt at mobility if they can, to wear them out, right? So there's better sleep at night. So there was lots of education that we needed to do. The big factor there was really addressing the turning practice culture in our ICU. That because a patient was on this doesn't mean that they can't be repositioned, but that repositioning can occur quietly and safely without a lot of disruption. And we had to provide some tools and techniques on how to achieve that. It also helped us really think about other turning culture that we had in our unit, whereby many staff just thought our patients were too sick to turn, right? And what we know from the literature is that while hemodynamic instability is a really, it's a real thing in our ICUs, and it's something that staff face all the time. The best way to combat hemodynamic instability is with improved mobility and turning. So starting with those micro turns. So this tool allowed us to place sensors on those patients and monitor for those micro turns, really looking at 5-degree or 10-degree angles, and then slowly increasing over the matter of hours or days, depending on what that patient's tolerance was, so that we were achieving better outcomes. Something I would like to do beyond this study is to look at how that might impact those patients' outcomes and their length of stay in our ICU. So there was lots of ways that this tool really helped us address our turning culture, and it started with those delirium protocols to have a big impact on our patients' outcomes. So thank you for that question.
Oh, thank you for all your great answers to all these questions. Another question is there an additional cost to the patient for the leaf sensor?
I think that's something that each organization can look at individually. We opted not to charge our patients for the cost of the sensor because we found that with our payer mix index, there might be little benefit into doing that and a lot of work to track that. Other organizations might feel very differently. So I think that potentially there is a model for that in the future. I don't know of any organizations utilizing this tool that do that, but I think that can be explored.
Another question is asking about device-related injuries. Does your team do any work on these, and can you speak a little more to that?
Yeah, when we talk about pressure injury reduction from a leadership perspective and across our organization, obviously we wanted to address all injuries and not just sacral or turning related injuries. 60% of our injuries were sacral, but we still had to address the other 40%. But what we found during our pilot period is that by having our staff really focus on pressure injury prevention, that translated into the device-related interventions as well. We saw improved partnerships with our respiratory team and other interdisciplinary teams to help reduce those injuries that were related to devices like, our oxygen tubing or intubation tubes. So we were able to see a significant reduction in both. Obviously, the lead sensor really helps us look at those turning-related injuries and non-device-related injuries. But subsequently, just by increased awareness and focus of our team, we've had a positive impact in all areas.
It seems like there's a lot of interest in the staff response. This question asks, have you seen an uptick in staff injury due to the manual turning and repositioning? And if not, what equipment is being used to circumvent that?
That's a great question, and I don't think Mayo is unique in this area. We're fortunate enough to not have very many lift injuries for our employees. It is a metric that we look at and monitor fairly consistently. That said, we are fortunate enough to provide a number of different tools and resources to help support patients, support staff in the mobility of patients. So we have portable devices, we have ceiling lifts in every room, and the portable devices, I think we have 4 or 5 different styles and types, right, based on patient condition and need. The challenge there is always encouraging our staff to consistently utilize the devices, right? And we have challenges like small spaces or larger patients or where it's much easier just to grab a friend and go in and move a patient. So I wouldn't say that we've seen an uptick or a trend or an increase in those injuries, but it is something that we look at, and it's a separate challenge to really encourage to utilize the supportive devices with their turning. The bed turning really helps us achieve the positions that we're looking for and then to place the wedges. What we know about the bed assist, turning assist, is that we can't only leverage that technology because it's not removing that mattress or that barrier from the patient's back. So really using that to help us turn our patients or with the ceiling lift so that we can properly position patients. That education was really important before we launched the sensor utilization.
Another audience member wants to know, what are some of your thoughts on turn teams?
I don't have a lot of experience with turn teams. This is a recommendation that we received when we started our lead pilot to see if this would help. Again, without any experience in leveraging FTE to support that, I would say that, thinking about how we communicate to our teams and when those interventions are needed would still be a barrier. Another significant difference is the ability to document in real time those nursing interventions. So I think those are just pros and cons that an organization would have to outline if they were thinking about leveraging that intervention over something like the intervention we tried, which was the lead.
And lastly, we have time for one more question. Will this be adopted by other Mayo hospitals?
Actually, we are in process of doing that currently. So Mayo Clinic has destination medical centers in Rochester, Minnesota, Arizona, and Florida. And we have a number of other sites, health system sites dispersed across Wisconsin and Minnesota, to include London and a new site in Abu Dhabi. We are working to expand the LEAD system at each of our destination medical centers and then other pockets across Mayo facilities where we're demonstrating a need for pressure injury reduction. So this is something that we hope to leverage within the next 4 or 5 months will be a tool that's leveraged by all of our Mayo Clinic sites.
Great. Well, thank you so much, Robin. That is all the time we have for today. I want to thank both Anne-Marie and Robin for that excellent presentation, and Smith and Nephew for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. And again, thank you so much for joining us, and we hope you have a wonderful afternoon.